Okay. Welcome again, everybody. Just for the recording, this is the Care Coordinator September 2024 info sharing, monthly info sharing session. Um, I want to go ahead and share our agenda. And just give me a second as I arrange everything on my screen. And like I said, today's main theme is overall uh, access to care or services, and more specifically through the assessment and the experience of the assessment. And I'm going to go ahead and see if I can make this look a little better here for us, a little bigger maybe, possibly. Can everybody see our agenda okay? And this is a Zoom, so you can unmute and say yeah, or just give me the thumbs up. I see a couple thumbs up, so I'm going to say it's good. Okay, awesome. So today we're going to talk about assessments and applications. We have a couple documents to share with you. One of them is about medical records that people would be gathering for you, the care coordinator, in order to perform the assessment. The other one is a tip sheet for individuals and families, which I think we did give out before, but we're happy to share it again. Um, and that's pretty much it for right now today. This is of course, our resources that we always share. And it's pretty simple. I'll be sending you this document after our session is over as well. So let me call up my next document here about assessment. We did visit with our assessment team, to vet this with them, just to make sure that it was good, look good to them, and would be useful for you and practical as a care coordinator too. All right. And so now we're sharing our initial applications. You should be able to see it. It says initial applications preparing for long-term care. All right. So let's go through this a little bit. Generally, what we're hoping to convey here is that um, people are, we get our waivers through medical necessity, but our waivers and the experience of going through pretty much everything with the waivers should be person-centered. So people oftentimes will need support to describe their needs and just describe barriers to living independently and being included in their community. It's hard, especially hard for a care coordinator, because you're going through, a medically based system to determine community care needs and to help a person fully express their life in the community with the supports that a waiver would bring. So there's lots of times that we'll be talking about medical needs. So we want to be aware of how we can help families do that and empower them to do that. So we wrote, a care coordinator can help the family and person by empowering discussion about disability, conditions, and barriers, helping a family become more confident and more trust us, meaning a care coordinator, trust the care coordinator to listen and have a respectful conversation with them and help make it as easy as it can be. We know the system is complex and asking for medical records is difficult. When we're done talking about this, what's on the screen here, it would be great if you could share some tips about working with families, about sharing diagnostic information with waiver, with through the waiver experience. So we're saying that building confidence in people and families helps them advocate for themselves as they navigate it, and the end result can be more person-centered services. There is diagnosis involved in every phase of this, especially with our application and assessment, and of course, reapplication. A diagnosis is required. It's part of qualifying for services. But people are more than their diagnosis, as we know. Um, a care coordinator can help the person and family prepare for their first application and assessment by helping them describe how the diagnosis impacts their life and how it requires long term supports. This is basically a conversation that you have with the person about, well, you have a medical condition. What does that mean in everyday life? What is it that you can do? What is it that you need help with? And that type of thing. SDS understands that people experiencing a diagnosis may experience it differently. We want to know how their life is impacted to make sure the right supports meet unique needs. So a person may have a certain diagnosis, but it doesn't impact everyday life as much as the facility-based level of care. So that person wouldn't meet level of care through the assessment process. More commonly, much more commonly, people oftentimes don't have the words to describe it, or they bring um, the system and the experience through this, getting these services through the system puts up a lot of challenges and barriers in and of itself. So people are not empowered to describe or find information that can help them with their support plan and with their eligibility process. So we're hoping to give you examples that, like in the next paragraph, to practice the conversation, uh, limit such as but not limited to. When did you start noticing symptoms of your diagnosis? What what doctors did you see to find out about this? What does it mean for your everyday life? What is it that you're good at? What are ways that you take care of yourself? And I wouldn't say good at, necessarily with every single person, because good and bad isn't really a way we want to approach this. We want to talk about what is it that you feel like you can do on your own, and what do you need help with? Who gets those needs met now? How do you get these things done? Are What are some ways you take care of yourself? Are there things you can't do or need help to take care of yourself? And what does a good day look like versus a hard day? These are ways to sort of personalize the experience of disability beyond diagnosis. Meaningful medical records. Medical records that you submit to SDS should document and educate the support about the supports needed. They should support that. We need to see records that relate to the diagnosis and conditions that result in need for long-term care. Um, we certainly have had an interesting journey to the present day in terms of records turned in to SDS. A lot of times we're training here is that, hey, it's confusing. I don't know what to turn in. I'm just going to turn in everything. A lot of people have a lot of medical conditions, and some of them don't really impact their need for long term care. Um, a basic example is like if somebody wears glasses, they have glasses, and it corrects their vision to the best possible ability. It really isn't something that impacts long term care. So we wouldn't necessarily turn in that record along with everything else that does impact the need for long-term care. Another example could be two people have diabetes. One person has eye degeneration related to it. The other may have circulatory conditions resulting in loss of sensation in their feet. The medical records would not be the same from the same provider types, an optometrist versus a podiatrist. Only the records that document the conditions and treatment related to their care and diagnosis should be submitted. So we wouldn't necessarily expect to get records from somebody else in the we could have records from their overall diagnostic, their general practitioner. But if an optometrist was helping them with this issue regarding their disability, then we would get records from them or from their podiatrist, and that affected their everyday life because of their disability. We would get records through that provider. A complete medical record set. Let me see if I have any more down here. Okay. The complete medical record set. I think probably before I start looking at that, I want to ask if there are any questions or comments so far. Anything to ask or say so far? Go ahead and unmute yourself and just let us know your question. If no questions, that's okay too. And you could chat them in. Comment says getting medical records is a nightmare. We put requests out months in advance and very rarely get things back. Yes, it is a common thing that we do hear about that. And it's kind of went down during the COVID era. And we don't hear it so much right now today, but I'm not saying it's not a thing because it is. It is. Generally, what we say for asking for medical, well, let's talk about asking for medical records, as a separate topic. Okay. We can talk about that as a separate thing. We just make a note. All right. So, what is a complete medical record set? Thanks everybody for your comments. Go ahead and share them. Everybody can read them, and perhaps we can, get into these discussions and provide tips when we're done here with this document. Um, okay, a complete medical record set includes medical documents that are related to the person's long-term care needs, right? Doesn't have to be everything. It's records that impact their long-term care needs, what's going to bring them into level of care. They're for a 12-month period from the date of application submitted and organized in a chronological order. The medical records could include visits or consultations with medical professionals, the 3 most recent visits to clinics or emergency rooms, records of a residential stay or any residential stays that are a nursing facility, hospital, psychiatric institution, or an assisted living home. Records of therapies provided by a qualified therapist for physical, speech language, occupational, or respiratory therapy. Thank you for your comments. Keep thinking about it. Mhm. Okay. Records of psychiatric or mental health counseling or treatments provided by a qualified therapist or physician, nurse practitioner, or physician's assistant. A complete record set can include special treatments such as IV medications, parenteral nutrition, testing, home health services, or hospice services. Also, outpatient treatments such as chemotherapy, radiation, or dialysis. These are all records that would impact a person's determination of level of care and would be a great support for our teams to be able to understand what is requested in a plan because we know how a medical condition affects everyday life. And these are great to support the overall understanding of the person in getting their records and why they're important. Okay. So this is a great list and a great document to guide you and help you have a conversation with the person about why the medical records are important and why we're asking for them. We do want people to feel empowered and to feel that a lot of people, well, we do get feedback from people we serve about the medical nature and the medical model and things like that. We realize we work within that. It is what the waiver is right now, and it's that way across the land. But we're hoping to bring this into the zone of meaningful medical records for people and to hopefully give you some clarity about what you're looking for. Um, so you don't have to pursue every single thing. Like we don't want to get when the person has aftercare instructions for a medical visit. We don't need those. We, believe it or not, we get gigantic packets of pretty much everything under the sun, and we don't need those after treatment, you know, instructions on how to care for yourself after the person has a surgery or something like that. Okay. And your feedback is great. I really appreciate it. We do
Um,
have a, yes.
Hi.
Hi.
I just I guess I have a comment. So it says the three most recent visits to clinics or emergency rooms.
Mhm.
I always provide the last 12 months, and I find also that the some of the assessors want to know like how many visits were there in the last 12
Mhm.
months. And even during the assessment, they have the records, but I'm reviewing them and
Mhm.
I'll say, okay, oh, it looks like there were six visits. And then I think
Mhm.
those ER visits are pertinent to
Mhm.
really showing, the acute needs of the
Mhm.
person.
Yeah. Well, I get you. We did run this by our assessment team, their leadership. So, I'm not really, I can't say that you're only going to ever get asked for three. You may be asked for more. We're hoping that it is consistent and that your experience is consistent. But because people have so many different needs, then it could be that people are asking for more, that our assessors ask for more. But again, this is a guideline run through our assessment team, and hopefully it fits most of your cases. But thank you. And, there's nothing against submitting more. Nobody's going to say, hey, because of this document that training shared, we don't want all this. No one's going to count them and say, oh my goodness, you sent in 7 or 12 months more, no good. No, I mean, more is okay. We just want to provide some general guidelines so that you don't feel like you have to get everything, including the aftercares and things like that are not needed. And then, even more than that, is to help personalize it for the person. Um, it may help get medical records in the long run if people could be, we could ask people we serve to get a copy and keep a copy of their medical records for us. It may be, I'm not saying it's this way with everybody. We do end up searching for these a lot. I see some comments about how long it takes to get them from the facility, for example. It could be possible that somebody wants to, somebody would be able to give those to you when you visit. And sometimes, that would be great. It would be great because they're keeping those things on file for themselves too. All right. Let me go through the questions here or the comments. Yes, there is a letter about being billed for medical records. We are uh, facilities and offices are not permitted to bill for medical records. There is a letter out on our website about that. Um, if people say, well, we'll give it to you, but here's the fee, as a Medicaid provider, they cannot charge for that. So we give them that letter. It usually helps. And it continues to be an issue, and I see that. Uh, Comment says requesting them up to 2 months in advance. It is difficult and time consuming. Yep, there is. The letter from Dwayne says they can't bill it. Send it to the email on the bill. Oh, they sent somebody a bill with the letter attached. Oh, how cute is that? Yeah, a lot people just don't know. I know that this our group here knows that. People just don't know. Um, you send records request and the letter and you still get a bill from Alaska Regional. Yeah, they're you know, there's nothing stopping us. I was going to get to this is that if there's severe delays with asking for medical records and repeated billing, and we've communicated with somebody at the office that is on the billing, or there's an office manager or somebody like that listed. We've done everything we can and been reasonable about our request to get medical records, yet we still cannot get them. We can report it on our central intake. You can report those difficulties on the central intake, and our team would take a look at that and reach out and offer a reminder to the facility that, we can't issue billing for medical records when it's a Medicaid recipient, when it's a care coordinator asking for a support plan, for documents for a support plan. That will help us know exactly what's going on with who. Okay. And will help us support our facilities and providers to be more consistent for you. And I'm not saying it's going to help tomorrow and it's going to fix it, but it's what we have to be able to help. It sounds harsh, but we're going to know that. We certainly have taught that before. Here's a good idea. Please consider expediting this request. These records are required by SDS for waiver services. Mhm, mhm. I'm just reading so I can understand it better. And there is a difference between when the pandemic was in effect and now, because we are asking for medical records. Before we were not, and now we are. So you'll have some hiccups and quirks with that for sure. Yep. And again, my best suggestion is if we've been, diligent in trying to get records in a timely way and explaining who we're working on behalf of and the fact that they're a Medicaid recipient and you still don't feel like they're helping, you can report them. It's not going to fix it right away, but it is a good idea so we can help others understand about who we serve. Question says, are you going to change the application wording? I I am not familiar with the reasoning around that. If you want to send me an email so that I have a better way to to understand that, you could send it to sdstraining@alaska.gov. I don't know enough about the need to give an answer right now or to suggest the process. Um, yes. All right. Nurses doing assessments want all the records, even records that were not even generated until after the application submission deadline. Okay. We'll bring this feedback to our assessment team. Get the year. Who wants to request 2 times because the assessor wants more? Yep. I'm just reading. It's difficult to get additional documents or changes to the QDC within the 5 days. It takes months to get what we get. Okay. Says if you can't get the records, there needs to be a way to submit the waiver application without them. I get that idea. Um, it is not an option right now today. I know it has been as an exception with our pandemic procedures, but it is not an option right now today. But I appreciate your comment. We'll definitely share it with our team. I'm just reading. Got a 15-day closure notice for an elder admitted and then discharged. SDS was requesting discharge notes. Okay. And with these different cases, you can always reach out to us. You can reach out to care coordinator support or even our assessment unit to for clarity on these individual ones. Okay. All right. I'm just reading. And uh, there's info here says there's a difference in facility and hospital assessments compared to home assessments. SDS needs to gauge post-discharge needs. Awesome. All right, some of the off-topic questions, I mean, I keep a record of them, but we won't address them here. But thanks for submitting. You're welcome to submit them. We do have your questions. So there's a question about changes to regulations, the same timeline and process as changes to COPS. Basically, yes. COPS are referenced in regulation, so it's it's basically the same process. They go through a proposal and a public comment period, and then a final version. All right. So let me grab a different document here and share it with us. Thanks for all your feedback. Really appreciate it. It really helps. And I'm going to share this one. This is tips for individuals and families. Just bear with me here as I move things around so I can see them better. I'm not the Zoom despite all the practice I'm getting on Zoom, it's not my main thing. Okay. Um, Tips for families and individuals to prepare for an assessment for a nursing facility level of care prior to an assessment. If a person can download and make a free Zoom account on their phone, tablet, or computer for a virtual assessment. An assessor, this is you can go by this to help people understand what it's like. It's in addition to our brochure that we have online and just a little bit more detail about things. The assessor asks about health. They ask about how the person does everyday things. They ask to sit, stand, and move around. It's best to find a quiet area in the home with enough room to move around. Bring your medical information to the meeting. Contact a doctor or use their online health portal. Have your photo ID available. If an assessor will be coming to your home, put away pets and put away items you want to keep private, like weapons, drugs, or other illegal items. We're not looking for those things. We're just there to see the person regarding their health. If you need to give more directions to find your home, work with the care coordinator, please. If it's some of our homes have pretty unique ways to find them, landmarks and things like that. It's really helpful to let our assessor know these things so they can get there. Describe how an assessor can find the home and pass the information on to us. Who may attend? The person seeking support will be at the meeting. If they have a power of attorney or a parent or guardian, they must be there. This is if the person seeking support is not their own guardian. If they're acting on their own behalf, then of course they should be there. They have a power of attorney signing documents for them for their waiver or intend to, then that person should be there. The care coordinator can join. The PCA could be part of the meeting to assist. You can bring a main caregiver to the assessment. A state employee from the assessment unit will be present, and there could be an interpreter in attendance if needed. For scheduling an assessment, the assessor could visit at home or video call on the cell phone, tablet, or computer. An assessment can take up to 2 hours to complete, and we should let people know to choose a time when they would be free for the whole meeting. If the person needs an interpreter, ask SDS for one. They need to reschedule, tell the care coordinator right away. The care coordinator can help tell us about what the person needs. During the assessment, please avoid smoking or using tobacco and avoid consuming alcohol during the assessment. The assessor will ask many questions. They'll ask about diagnosis, health, and medications. Answer all questions honestly. If a person provides false information, it might cause them to lose their right to supports. For the ICAP, inventory for client and agency planning, for our IDD, ISW, and DD eligible APDD, actually, it's just the ISW and IDD. Sorry. Um, for the ICAP, prior to the ICAP, be sure to fill out and sign all the forms. Choose 3 adults who know the person's limits and skills. They'll need to answer questions about the person seeking support's functional abilities. It can be one parent if both parents live with the applicant. Can be a teacher, can be a therapist, could be somebody who knows that person really well on how they function in everyday life. And submit the filled out forms to the care coordinator and do so as soon as possible. For scheduling an ICAP, an assessor will contact to schedule the ICAP. Notify the 3 people that SDS will contact them so that they're not, surprised if you want to say it like that. um, you're gonna have somebody talk with you about the ICAP. Be ready to schedule a time for the observation, part of the assessment. During the ICAP process, there the observation period is required. This best occurs in a natural environment where the person is familiar with what they're doing and a familiar place for them. You can complete the ICAP over the phone. You do not need to complete ICAP and observations at the same time. And as always, please be honest when answering questions. And that is the end of that particular document. And this is something that can be given to individuals and families and shared, and we'll send it to you as well. Okay, I'm going to go to our general chat here. Okay, so I am going to go ahead and invite our our nursing unit manager, Molly, who's here today, to go ahead and talk a little bit more about these processes. Molly, you're welcome to go ahead and unmute and talk.
Thank you, Kara. Hello, everyone. Um, uh, Great turnout. Looks like there's um, a lot of good comments, good questions in the chat. I've been trying to follow along. I hear what everyone is saying. I think the one thing I wanted to comment about was the differences in assessments. So when it's a renewal and you're submitting your renewal 120 to 90 days ahead of the level of care ending, I understand the requests for records are made much sooner. And then come time for the assessment, you're asked for additional documentation. Compared to an assessment in a facility or in a hospital, we do the significant difference there is the timing of information. So in a hospital, we receive the application 30 days ago or anywhere within that time frame. We're doing the assessment now, and information's already owed. Based on whatever is happening with the um, recipient when they're still in the hospital. And really what we're looking for are what those discharge needs are going to be. We have the information about what's going on with them in the facility, but it doesn't really help to kind of give us a good idea of what will be needed after they discharge. Will they continue to need outpatient physical therapy, occupational therapy, speech, or wound care, or any of those things? We're trying to get a better understanding of what will be needed once they discharge. We get about what's happening with them while they're inpatient, in acute care setting. Everything is everything is being provided in the setting that isn't necessarily the same kind of setting they'll have when they get home. So sometimes the information, I understand it can be daunting to try and request information. It is a little easier for us to request information when they are in the hospital. We connect directly with the social worker or the discharge planner. And many a times we make the request for records there. Sometimes when we're not able to connect with them, then we're asking you to see if you can get them. Sometimes when it's a renewal, it's really dependent on the information. If there's information from the time frame you submitted documentation, then come time for the assessment and there are questions about it. Some things have been, for example, we assessed someone who was in the hospital, who was discharged from the hospital 3 months ago. They were back home. And according to the documentation, it mentioned that the person was discharged with with an IV line, with a PICC line, for medication that they were to continue to have for a couple weeks after discharge. So the question was, is it still there? Is it still? So sometimes the information we get leads us to asking more questions. We don't necessarily see it mentioned in the assessment, and sometimes second level review is looking at it, and there are questions about things that initially had them approved for waiver, and now it looks like it's no longer there. So just looking for that, for specific information to help. I know the list is pretty long and comprehensive, and we don't want you to have to go chasing after, hundreds of pages of records. We would rather be specific and be direct in the documentation we'd like for you to help gather, but it isn't always easy when it has to be person-centered, and things happen at different times. It happens between the time you submitted that application and when the assessment already is taking place. And so we appreciate all the effort and attempts. We are getting some records that are submitted, quickly. Some take a little bit longer. Some we actually try to sit on in second level review, waiting for records to come in. As long as we get some, we're communicating about, the attempt to get records. We've also connected directly with a provider where the care coordinator shared that she's tried multiple times with no success. We reached out to that provider directly and asked them to submit, and asked them, we tried to explain that the request from the care coordinator is important because this means the continuation of services. And it really helps us to see and understand the person better. So where we can help each other, we're absolutely, we don't want to make more work for you, but sometimes it's a need. I don't think we want to really request any more records than we have to look at. It's really where there's a need, looking at level of care, whether we can continue to approve it, or where we shouldn't be denying someone because there's information that might lead to level of care, or a service. So we appreciate all that's being done, and appreciate me taking a few minutes of your time. So thanks.
Thank you, Molly. Yeah, this is great information. We had a couple questions here. Uh, there was a question about harmony formatting. I would like to be able to bring that to Kat and our overall team. It's about a latest format, so we'll address it in a different way, just not here in this forum. Question says, I've had a nurse assessor tell me that for any therapy, she needs the most recent 7 visits because of possible improvements. It says regress. I don't know if that's the right word, but because of possible improvements over time. Should we always make a second request? Molly, what do you think? We had in our document that 3 visits, but I guess our assessor nurses asked for 7 visits because of possible improvements over time.
I wonder if that means the therapy notes from the last 7 days. Was this a hospital assessment? I'm wondering. It can go either way. It's really hard to, if there are records indicating someone should, uh, or someone had discharged from physical therapy, it's usually because they've either met their goals and they're back at baseline functionality. And then come time for the assessment, that's not really how they um, demonstrate, their functionality doesn't really match that. It's really when there's a question. If there was an improvement, it's hard to nail down because of the timing. Uh, it's I would say for hospital assessments, and they're still in there and they need to get out, or they're working on discharge and we're trying to gauge, what truly that functionality is, and maybe get a good understanding of, why things don't necessarily match, when records say one thing, but you don't really see that. That's usually where we look to records to really help explain that.
Okay. Thank you, Molly. This is great. I guess there's a question here that is about an expedited review for an inpatient assessment that gets denied. What could you share with our group here about doing expedited um, request for expedited review that get denied when the person is inpatient? Is there anything special to know, or any tips or anything like that, trends that you see about that?
Yeah, so when there's a request for an assessment to be expedited, it's the only requirement really is the form, the request for an expedite form. And on the form, you're checking which box applies to the patient. Um, and if there's documentation you want to submit to support the expedite, that's absolutely fine, but the letter is not necessary. The letter from the doctor explaining that they would like for us to expedite the assessment because they need to discharge. It's good information to have, but it really doesn't necessarily weigh in as much as you just letting us know, or a record that says, anticipate discharge will be on a certain date. So of course, any of the reasons lined, in the form will qualify, or have someone meet eligibility for an expedite, and if it doesn't, then it doesn't. We do, however, prioritize all hospital assessments. So we're there always has to be someone first in line. So expedites are always reserved for those who truly meet the criteria for an expedite. And then those who we prioritize, anyone who's in the hospital would kind of be the next level or the next person up in, in line, and then maybe an initial. So it isn't necessarily required to have a letter from the doctor. I see that a lot, but it's good information, but it's not necessary.
Okay, I got the form. Thank you, Molly. The network's a little slow today, so I apologize. But this is the form that we've been discussing here.
This is
Sure.
Susie on the imminent discharge area. Yep.
Mhm.
Where you have to put in the date. Usually I do see assessors ask me for a letter stating when that discharge is happening or is expected to happen. And I'm not sure if that's what Tanya was referring to for the letter.
It could be if there is nothing else in the medical records that has that information. That might have been a request from Paula, who's usually reviewing our expedites. But if it's in your medical records, it's not necessary to have another document written to provide.
So this is Tanya. I wrote the question because I do this form, I put the discharge date on it. The hospital gives me a letter with the same discharge date on it. And Paula said that an imminent discharge is not a reason for an expedite. Great. So let's not waste time. Let's not have to do the form if we're just going to fall in line because they're hospital. But I put in an application without it, and I get kicked right back saying have to do an expedite form. So I guess it seems like both ways. The care coordinators are doing more work. The hospital's doing more work. If they don't have to write a letter, they have to put it in the chart note saying what that discharge date is, and we have to provide it. But if that's not a valid reason for discharge or for an expedite, then why do we even have to do this?
So not sure what those instance specific cases might be. It is a qualifying criteria on your expedite form, imminent discharge within 7 days. I will say common practice in hospitals, because we accept, when it's an anticipated date and not necessarily, a target date that has been established and will happen. That's what we're looking for. Someone is truly exiting the hospital on the date that's there. So what usually happens is we'll reach out to the person who wrote the letter or the social worker to discuss the details of the discharge. And if it's something like, well, we're just waiting for a level of care, and then the person can be discharged, we don't find that as a qualifier. We will expedite assessments for people who are leaving the hospital on the date specified. And that's sometimes where it gets confused. I know people, providers want, assurances that they meet level of care. I understand all that, but we can't expedite every hospital assessment. That's just not possible. We're not able to do that. So this process is how we've been able to manage all of the expedites requests coming in, because every hospital thinks everybody discharging, understandably, with the challenges we're seeing in our hospitals. But all hospital assessments cannot be expedited. We don't have the manpower for that. And many a times when we do connect with the hospitals, it's really there are other things complicating an actual discharge date that has nothing to do with assessment. So we manage the information, whatever the information might be, but we do reserve expedites for true expedites leaving the hospital on a specific date.
Thank you, Molly. Okay. Thank you for this great discussion. And I haven't seen new comments come in. Okay. Okay, there's a question about how to run reports in PayerPath or Enterprise. I think that if you have questions about PayerPath or Enterprise and running reports, I would direct them to the MedicaidAlaska.com training unit, because they will help. They'll help with that type of thing.
I was just hoping that if somebody here already knows how to do it, they could give me some tips, because getting answers out of Medicaid is not easy.
And that's
And
Jennifer.
what I've found by asking other care coordinators is pretty much everybody I've already asked is doing it manually. And so I figured others might appreciate finding a more automated way to do it if there is one.
Does anybody have any tips or any assessment related or helping a person be empowered for their assessment? Anything that has worked for you with helping serving your individuals? Okay. Suggestion for Jennifer, you might try asking on the Alaska Care Coordination Collective site. I don't know if that's the Facebook page. Might be helpful. Okay. All right. Well, I don't see any other comments coming in. We'll go ahead and bring our session to a close. We'll get the recording ready for you. Okay. Lois is talking about how very personal the assessor's questions will be, empowers the person and helps them be less intimidated. That's great. And just, sort of make it be okay to talk about. Everybody comes in with a different level of empowerment versus challenges versus self-awareness. So just make people know that it's okay to talk about those things. That's what you're there for, and it should always be respectful. And we know that people experience medical conditions and people experience disabilities. It just help people get more familiar with that it's a welcoming, safe space to talk about those things when you're with your care coordinator and through the assessment process. All right. Like I was just saying, we'll get the recording ready for you. We'll get the email ready for you and send it out. Please give us through today to get that done, and maybe tomorrow too, depending on my network stuff. If it stays, sometimes it's hard to get a long recording up on YouTube, but we'll be working on it right away. So just look for that. Thank you, Molly, for your wonderful answers and for being part of our discussion today. Molly Atanoa with our supervisor for our nursing unit. Very appreciative that you were here. And we'll go ahead and close our session for today. Thanks again and have a great rest of the week. Goodbye for now.